Do you guys want to introduce yourselves?
So I am Dr. Roland Zhang. I am the not so smart but very good-looking co-host of the show. Joining me today is the wonderful, very talented Dr. Jessica Udago. If you would like to say hello, say how we met, and definitely show off. You know, we get a color coordinated. Yeah. Do you appreciate that? Big one up. Yeah, we're ready to go.
Oh, I didn't get my superhero memo.
You always look like
you got the S on the chest. Yeah, so like Dr. Zhang said, I'm Dr. Jessica now, Udago, and I just graduated actually from SJSM earlier this month. What else to say? I'm in Texas right now. Sorry for those who are in Illinois, because here it's like 60 degrees. And right now I just finished interview season, and so I'm just kind of thinking about my rank list and hoping to match in March. So it's exciting.
So congratulations, Dr. Udago. We have a very special show, a little bit different than traditionally. So Dr. Jessica has not seen the question before, ever. So she'll be going into this cold, which, you know, gotta give her full kudos for that, you know. The audacity, the confidence. But Ms. Megan, can you share a screen, please?
Right now, we don't know.
Do you have the shared screen up?
Is it working?
Yes, here it is.
Perfect.
Okay. Also,
okay,
before we start today, Dr. Roland and myself are in Chicago, and it's currently really snowing. So when we were testing this out, we had a couple power outages, so hopefully it goes smoothly, but if it doesn't, bear with us. And yeah, let's go on to today's question.
Perfect. So today we have a 23-year-old female with abdominal pain. So once again, our wonderful guest speaker, Dr. Jessica Udago, our lovely Megan, as always, and then there's me. So, Dr. Udago, if you don't mind reading this to yourself, for all our students playing along who's kind of read this before, write down what answer you think is correct. And Dr. Udago, if you don't mind kind of going through this, you know, what do you think is going on?
Okay.
Also, Dr. Zhang, do you mind putting it on presentation mode so we can see it a little bigger?
Yes, please.
Is this not in presentation mode? I'm sorry, I thought it was.
No, you're good. There you go.
Perfect. Okay, I'm sorry. So Dr. Udago, the students have seen this already, so you don't mind kind of reading out loud or however you think they know about it.
Okay. So for me, I read the stem first. Which of the following would be most efficient to determine the cause of this patient's symptoms? And then I go to the vignette part. And so a 27-year-old woman comes to the emergency department with severe abdominal pain. So I read the first sentence and kind of get in my head a list of differentials. So she's 27. A 27-year-old would be a childbearing woman. She came to the ED as opposed to going to a regular doctor's office. So that can kind of tell us she's in a lot of pain, and it says severe abdominal pain. So that's also something to consider. So in my head, I'm thinking a 27-year-old, it could be like an ectopic pregnancy, it could be appendicitis, it could be what else? Like if there was any type of trauma, something related to a trauma, which we'll read on to see. I'm also thinking, okay, what side is it on? Where is it at? Also, her size could be a component when you're thinking about like gallbladder issues, et cetera, et cetera. So that's what I'm thinking, but this is just usually all in my head when I'm skimming down the question. And so she describes her pain as an 8 out of 10, limited to the right lower quadrant, non-radiating. So in my head, that kind of eliminates a couple of things like kidney stone or something like that. No alleviating or aggravating factors. Her other symptoms include nausea, vomiting. So that kind of puts certain differentials to the top for me. She's sexually active with her husband of a year and a half, does not use contraceptive. Her past medical history includes infertility, family history of hypertension, diabetes, and in her mother, a family history of hypertension, diabetes in her mother, and hyperlipidemia in her father. She's currently taking a vitamin. Her last menstrual period was 7 weeks ago, so that's something that I would highlight. And then patient's vitals are as follows. She's afebrile, her blood pressure is good, and her respiratory rate is 21 breaths per minute. So then again, which of the following is most efficient to determine the cause of the patient's symptoms? So usually I would be highlighting along the way. So it's a right lower quadrant pain, which still allows me to keep appendicitis on my differential list and an ectopic pregnancy along on the list because her period was 7 weeks ago. They did say she had a history of infertility, but we don't know what that history is. We weren't given the details. So those are the two that I'm kind of thinking of right now from what I see. Let's see, I'm just kind of taking a quick skim, and usually I do this a lot faster. And guys, I have not done a question, and I cannot tell you how long. So
if you guys want to go in the comment section and kind of answer with her of what you think the answer is, that'd be great. I know you may have done it last Thursday, but just to rebrief everybody.
And it says most efficient.
Most efficient.
So to determine the cause of the patient's, and it wants to determine the cause as opposed to like eliminating a potential cause.
And Doc, if you don't mind, maybe running through all the answers, like why A would work, why B would not work, and so on and so forth. Same thing, echoing Megan for all of those playing along. Choose the answer, but if you want to write a short blurb of why you think A is incorrect, B is correct, or what have you, come play along. You know, there are no wrong answers here.
Yeah, it's fine. We're learning. We're all learning.
We're all
learning. If I get it wrong, it's fine. This is for learning.
Yeah.
So, so A, surgical intervention, and thanks, Dr. Zhang, for that. So, okay, yeah, when someone you think for sure has an appendicitis, surgical intervention is usually you just go straight to that. So that can stay, but that doesn't, that can stay because I mean, even the ectopic pregnancy thing would, that may be something to consider. And then B, pain management. Okay, but she has, yes, we need to do pain management. Hopefully she has some pain management involved, but that doesn't answer the question. Abdominal MRI, that's something expensive. Usually we don't jump to the most expensive thing first, at least that's my thinking, the abdominal MRI. Abdominal x-ray, yes, we'll keep that. It's like a cheap, just to see what it is. I would think, in my head, I'm kind of trying to think what we use the abdominal x-ray for. So that's something to consider. E, when I first read the question and kind of saw, I was like, I want to see what E is. I want to see if she's pregnant or not, because her period was like 7 weeks ago. But then I'm kind of, I'm on the fence because it says, what's the most efficient way to determine the cause of her symptoms? And just based on what I'm given, I want to go with E. So I think that's my final answer. Because I don't want to, like, sometimes you kind of read too much into it. Because the abdominal x-ray, like, what does that show? A stone in the ureter? She doesn't, it's her pain is non-radiating.
Sure.
So, and I thought like with kidney stones would be radiating pain. Abdominal MRI, expensive. Pain management, we hope we're doing that anyway, but that doesn't help, that doesn't answer the question. Surgical interventive, someone said it, is like, that's too invasive. Like, whoa, we just jumped to that, but we don't know what, so we're just fishing around. And they don't have any like, basically peritonitis symptoms where you're like, okay, we need to get in there and figure out what's going on. So yeah, E will be my final answer. Sorry, it's a long explanation, but that's what I would normally do, like in a minute and a half, like without talking it out.
So great. So Dr. Hidalgo goes with choice E. So here's everything that I highlighted when I was doing the question. It's actually really remarkable that everything that Dr. Jessica went through, I kind of saw when I was doing the question as well. So 27-year-old female, severe abdominal pain, right lower quadrant, and like Dr. Jessica, not radiating. So you kind of have the big list of differentials. And things that I wrote down was appendicitis, ectopic pregnancy. I also have ovarian torsion, pyelonephritis,
Yes, yes.
and then maybe a tubal ovarian abscess as possible differentials as well. And I worked exact same logic with her. The last part will be the most efficient. Like Dr. Hidalgo, like which one's the most efficient? Not the most, no, the best, but the most efficient. So the correct answer is E, ectopic pregnancy. So for those of you who chose E, well done, right? Well done. So let's look at the vignette one more time. Oh, thank you. So I stole this from Dr. Armando.org. He has a great YouTube channel. We're not sponsored by any company, so I don't want you to think that we're getting paid by him. But it's a great resource, and he actually draws it along, which I thought was really interesting. So basically, what's happening in this patient? And actually, Dr. Hidalgo, would you care to explain, or would you like me to?
About what's going on with her?
Yes.
With the ectopic pregnancy, like how? I don't know.
Sure, yeah, absolutely. If not, I can do it. It's not the big deal. Okay, sure. So basically, in ectopic pregnancy, we have a fertilized ovum, right? So we start here, we have a fertilized ovum and implants somewhere outside of the uterine cavity, right? So outside the typical location where, implantation is supposed to take place. Most commonly in the fallopian tube. So let's look at here, in the fallopian tube around here, right? You can also have it in other areas, like let's say it gets stuck in the ovary, it can cause a burst ovary as well. But in this case, we're thinking in the fallopian tube. So because it implants here, it causes a lot of very painful symptoms, right? So the patient could present with fainting due to pain, vomiting, amenorrhea, maybe some shoulder pain with the pain radiating to that area as well. So they also have acute abdominal pain and then all kinds of bleeding as well, which makes logical sense, right? But in this case, I want you to take a look at her physicals. I'm sorry, her vitals. Even though she has all this pain, severe abdominal pain, 8 out of 10, her vitals are okay. She's afebrile, blood pressure is okay, respiratory rate is elevated, but once again, she is in a lot of pain. So you could argue she's hyperventilating a little bit because of the pain, right? Cool. So here are all the ways that they can actually present upon physical examination. But going back, what do we want to do? Well, first of all, even though she has all this information, we're looking for the most efficient way to determine the cause, right? So the most efficient way, surgical, yes, I guess theoretically you could poke around. Pain management doesn't determine anything. You're kind of masking the pain. MRI, I agree with Dr. Jessica, really expensive, doesn't really tell you anything. Abdominal X-ray, if she is pregnant, you do not want to hit her with any kind of radiation. So going back, you want to make sure, is she truly pregnant, even if the ovum is in the wrong location. So the Beta Hcg is the cheapest, easiest way. Are you actually pregnant, right? So one thing I learned, which I thought was really interesting, is the elevation of Beta Hcg. So for those of you who are studying for step 2 or step 3, if the patient has a implanted ovum in the fallopian tube, the level of Beta Hcg will not rise as rapidly as a normal pregnancy. So in a normal pregnancy, the Beta Hcg should, double every few days. If it's implanted in the fallopian tube, it will not double every few days, which I thought was really interesting. So you want to do a urine pregnancy test, and depending on the patient's symptoms, if it's, I believe, within the first trimester, use methotrexate to terminate the area, or you can do a laparotomy, laparoscopy, just take out the area, because it's a very, very dangerous condition, right? It could rupture, could cause severe bleeding, so on and so forth. So Any questions so far?
Not as of right now. People were responding before to what they thought the question was. Does anybody have any questions right now, of what Dr. Rowland is talking about? Or, so Kristen, the answer was E, as in echo. Yes. There you go.
Yep.
We'll always go back to the comments.
Sure. So my apologies. E is an echo. So Beta Hcg. The very first step. Let's confirm if she is pregnant or not. Right? Does she actually have an ectopic pregnancy? So surgery would most likely be the next best answer, if and only if she's crashing. If her vitals are unstable, maybe we need to do some immediate surgical intervention, really hit her with fluids, make sure she's stable, right? But right now, based upon her vitals, because she is stable, we want to make sure, does she truly have an ectopic pregnancy? So once again, E is the best answer. Okay. So I think it's a relatively to the point question. I did take the liberty of thinking of some differentials, and ectopic pregnancy, I think, was my number one. Appendicitis was definitely number two. So for those of you who can actually play along, what test am I thinking of right now based on this picture alone? So open-ended question to all of you wonderful viewers, students as well. What am I thinking of? Dr. Hidalgo, care to venture a friendly guess?
Yeah, I was thinking McBurney's point.
Bernie.
McBurney's point. Yeah.
It is.
Yeah, you like that? So I know my memes, right? So thank you for to all of you who play along. Here's some bites that I want you to think of, as in what could cause a ectopic pregnancy. So in this case, let's say she had pelvic inflammatory disease, right? So what kind of ways could a test writer make this question a little bit more difficult, a little bit more challenging? What if you want to spin it towards a micro question? For example, she was exposed to chlamydia or gonorrhea. How can you test you in that way? Or they could ask you, here's a slide on it. Can you tell me from a slide, what bug am I thinking? What if I describe it? What if it's a gram positive, gram negative, intracellular, then what, right? So these are easy ways that the test writer could make it a little bit more challenging. Then going back, if the patient's vitals were crashing, if the patient was unstable, how would that change the overall framework of the question? And the last two is something I've always kind of tried to promote. Think of this as a patient who walks in through your clinic door. So you're the doctor in charge. You have a 27-year-old female walking in through your door. She's holding her abdomen in pain. What do you think, right? Instead of looking at the vignette to give you the information, what would you want to ask her? What kind of testing would you want to do? So instead of thinking about from a test taker perspective, take a step back and think of it. If I was a physician in charge, what do I do? What do I want to ask of her? What do I expect to see upon those labs, imaging, and what have you? Cool. So thank you. Before we let you go, I wanted to ask Dr. Hidalgo some of her insight. So Doc, what kind of resources did you use when you prepared for the MBME and STEP exams?
Okay, I had to kind of quickly write this down. For step one, I used UWorld was my main question bank with first aid as well. When like my UWorld lapsed, and I think the step one at that time was cheaper, so I would like use that to supplement. I did OME, online med ed. I did Boards and Beyond. Was really good. Boards and Beyond was really good to help me kind of solidify my foundation in terms of like physiology and pathophysiology. And then I also did IOMB, which is Institute of Medical Boards. They had a like Skype sessions. I would do weekly Skype sessions. And this was for step one. I would do weekly Skype sessions with a tutor just to kind of keep me on track. He like made a schedule for me, so I would follow that schedule and just check in with him weekly to make sure I'm staying on task. So that was for step one. For step two, I used OME and UWorld. that was pretty much it for that. And then I would, if there was concepts that I didn't know, I would refresh by reading, or I would refresh by going to finding the YouTube, like the YouTube video to help me understand concepts. Because I think that's pretty much the key of all of it. Like try to, at least for me, I should speak for me, try to really understand what that thing is, especially if it's a high yield concept. Understand that concept and you can kind of figure out the rest. So that's pretty much what I used. And friends.
And friends.
Friends will always
yeah.
To finish off that, I think you brought up a very good point that studying for the MBME, studying for UL, studying in general is a very long, tedious, and difficult thing to do. And I think the good thing is that Dr. Hidalgo and I, having gone through the system, we understand how incredibly challenging it is. So we were actually talking right before the webinar started about having a group a social support group, right? And Dr. Jessica, I think you're much more verbose than I am. If you don't mind just telling everyone what you told me, which I thought was a very eloquent and very logistical approach that, unfortunately, I didn't think about that until many years later. So the floor is yours.
Yes. So when I did the 4 semesters on the island, and then the 1 semester was in Chicago for AICM. And while I was there, they had a couple of people come in talking about prep courses and stuff like Kaplan and Becker's. And I went to like a Becker's, like just informational meeting. And basically he was just saying that, I can't remember the guy's name, and he's like a prominent person, but I cannot remember. He was basically saying in law school, the law students, they get together, they get their group and they study. And he's like, for whatever reason, med students kind of like get the information and then go down in the dungeon to study. And he was like, I don't think we should do that. And I had already been having my studying in a group on the island, and we ended up moving to Chicago together, and we ended up keeping up with each other. And that does really help studying in a group. And I know it's hard because, you know, you kind of want to like, okay, I rather you will tell me wrong than tell me I'm wrong. It's that thing I can walk away from than a person telling you that that's wrong, because I think it's part ego and it's part being vulnerable, because you have to expose yourself to someone telling you you're wrong, and then they have to explain why you're wrong, and then you have to kind of deal with that on your own. And in the beginning, it's rough, and you get mad and you get defensive. But in the end, it really did help me, because it helped me. You just know that you don't perceive things the same way that everybody else does. So it helps getting that outside view of a certain concept, because that can actually help you understand the concept better. So I advise get your study group, people that you trust, people that won't let you astray, because I've heard that some schools and sometimes people can kind of get pretty competitive, but if we're all going in the same direction, we might as well go together, not against each other. So I had a really good group that I trust, and I trusted their opinions. And so when they said, nope, that's not how I got it, or this is how I got it, or no, you're wrong, I don't see it that way, it really did help in terms of my studying. And then when you would come across that concept in testing, you remember. You'll go back in your brain and you remember having this discussion about this concept, and it is this, and there's no way it can be anything else. So it really did help. So I just encourage people, have someone you can trust. It does help when you have other people to bounce ideas off of and concepts on. And then also ask them, like, how are you understanding this thing? I don't understand it. What did you use? And it also helps you when someone asks you how to explain something and you can verbally explain it to them. So it's also teaching you in a way as well and solidifying your knowledge. So that's my recommendation. It really did help. And it helps to have the support and the venting and the cussing.
Perfect. Well, thank you so much. Any other questions, thoughts, concerns from our wonderful viewers? Anything you want to pitch from both Megan and Dr. Hidalgo before we let everyone go?
Hopefully everybody's questions were answered, and we had a great participation of comments coming in, which we love to see. We love interaction between you guys. So thank you all for joining us today. We really appreciate it. Thank goodness we didn't have any power outages.
I know.
Yeah,
Thank
a huge thank you for Dr. Hidalgo for joining me today. Really appreciate it. Dr. Jessica and I, we actually met in person in Texas. Had a very fun, really enjoyable.
Yeah.
So for those of you watching, if you have a question or a UO question or MBME question, which you think is a viable question you want to see answered live on air, send to Megan. You know, there are no bad questions. Actually, there are some bad questions out there, but if you have a good question, send to Megan. We'll love to have your information on air. And then, yeah, we'll take it from there. So
yeah, you can always
everyone.
our comment section, either right under this post or, direct message us, and we'll be sure to see it and get back to you guys. But thank you all for coming. Really appreciated it. You had a great time today.
As always.
Thank you. Thanks for the invite.